welcome to our Facebook Live. I'm really excited about Facebook Live today because usually I'm sitting here talking by myself, but today I actually have a friend with me. So I want everybody to meet Dr. Jeff Gray. He is the head of our embryology team here at Coastal, which is a very big job. We've got a big team, a busy lab, and so he does a lot. He is on site with us every day, which is a very unique feature of Coastal, and so he is here keeping everybody on track, taking very good care of all of our patients' embryos, and really the one who's responsible with his team for getting our pregnancy rates to be as amazing as they are. So we have picked to do our Facebook Live today on really lab stuff, I will say. Anything related to the lab, things that we may not talk about a lot on a direct patient to doctor consultation, but patients will hear the terminology, and I think it's important to kind of have some clarity on what that means. It's the appropriate day. It's World Embryology Day today, so we want to thank all of the embryologists in this country, in the world, and obviously at Coastal Fertility. So let's go ahead and get started. So I think probably, Jeff, the best way to go through this is just to kind of walk through what happens in an IVF process. And obviously you guys really play a role in IVF, so let's kind of start there. So after a patient has gone through their other medications, their first encounter with you guys is really at their egg retrieval.
That's correct.
So walk us through when they're getting their eggs out from the other side of the lab, what is happening? What are you guys doing?
Yeah, so when the ovarian hyperstimulation process is complete and a patient comes in for egg retrieval, first contact with the lab will be an embryologist will come and check your identity and verify your identity, your partner's identity, and the plan for your IVF cycle prior to any anesthesia to verify that we have the right individual, which is very important. Very important. But also to verify that the plan for the IVF cycle is understood by the patient and the lab. That patient identity and plan will be reiterated with the physician prior to the retrieval beginning. As the retrieval is ongoing, as the physician is aspirating the follicles from the patient's ovary, the embryologist will be just through a small window that goes from the OR to the embryology lab and will pick up the oocytes from the fluid as they're aspirated. We did our best to translate some real embryology pictures into the Facebook Live format.
I like it.
And what you can see, this printout here is of a patient's eggs. And so in the dark center, the dark circle, in the center of each of those little clouds there is the egg itself. They're surrounded by a variety of a group of cells called cumulus cells, and so this is literally what we're looking for at retrieval. So these are picked up and accumulated throughout the retrieval. Then when the retrieval is complete, the embryologist will put those away into an incubator and then come and visit the patient once they have recovered from anesthesia, inform them of how many eggs were retrieved in the retrieval and the next steps in the IVF process.
Great. So I think that that's a thing that patients don't realize, because you see us as your physician in the OR getting your eggs, but what you don't realize is right behind the window is an embryologist as we are sending them eggs, literally working under the microscope in real time, finding eggs and calling out egg numbers to us as we're doing it. So they are very actively participating in the process. So let's go on to later on when you are going to be assessing the eggs before insemination. I think there's a lot of terminology that we often will convey to patients, but they may not understand. So when we're talking about eggs, we use these terms M1, M2, GVs. What does that mean? What does that mean to patients and for their eggs and the process?
So eggs come in a lot of different flavors. What usable oocytes or eggs, again, interchangeable terminology, good for patients to know. We need a mature oocyte. Only mature oocytes are ready to give rise to an embryo when a sperm is put in them. So the technical term for a mature oocyte is an M2 oocyte. That means it is arrested at the second phase of meiosis, and it's ready to be fertilized. This is what an M2 oocyte look like? If you can see, this is the oocyte itself, and then there's a small structure called a polar body on the outside that indicates that it is in the second stage of meiosis and ready to be fertilized. Other oocytes, different stages, are not competent to give rise to embryos, and so they will not be ICSI'd or inseminated, as they are unable to give rise to an embryo.
So when we say M1s, that usually means an immature egg that cannot be inseminated.
Yeah, there are a variety of different types of immature eggs. M1 is the stage just before M2. Germinal vesicle or GV eggs are prior to that, so they are a long way from prime time.
Got it. Okay, perfect. So once we get the eggs, obviously the next step is to put them with sperm. So I guess next step would be to kind of talk about the different ways to do that.
Yeah, so two primary ways in which we inseminate eggs at Coastal Fertility and in general. The principal one is called ICSI. ICSI stands for intracytoplasmic sperm injection, and that means that an embryologist will take one of your partner's sperm and put one sperm into each egg with a microscopic tool. You can see in this picture here, that is an egg undergoing ICSI. So you can see the microscopic tool going into the egg. It is going to deposit one sperm inside that egg, and then we'll move on to the next egg and put one sperm inside of it. Important for me to say that at every step of this process, any partner's eggs and sperm will be witnessed and verified by a second embryologist. Everything in the embryology lab has a second set of eyes on it, because that is an exceptionally important part of the process.
Agreed. So this is, you would say, probably the majority, and I know the answer to this, but the majority of our patients actually would be fertilized via the ICSI method.
That's correct. The majority of our cases are ICSI. ICSI is micromanipulation, so is a little bit more invasive, but it is very predictable in terms of fertilization rates, very predictable in terms of embryo development, a technique that we use very regularly and have a very high degree of confidence in. We do additionally do conventional insemination of oocytes, where patients' sperm and eggs are mixed together in a defined fashion, and we kind of let the sperm do their thing. This is appropriate for some patients and in some cases, but in most cases we do find the predictability and safety of ICSI to be the most appropriate method of insemination.
Perfect. And so that would lead us to the next question. When you put the sperm in the egg, how do you know if it fertilizes? And what is that called, and kind of what would the next steps be that the patient will be told?
Yeah, so on the day of retrieval, the eggs are retrieved, the surrounding cells around the eggs are removed or stripped, so you'll hear this term stripping, and then ICSI occurs. So that's all on the day of retrieval, or day 0. On day 1, the following day, an embryologist checks the eggs for fertilization. And I'm not sure that this picture will translate incredibly well. What an embryologist will be looking for in an egg that has been inseminated is two small circular structures called pronuclei, and that is essentially the DNA and chromosomes, one from mom and one from dad. And so if we see two of those circular structures, we know that the egg has fertilized appropriately. So that would be referred to as two pronuclei, or a term you may hear, an abbreviation, a 2PN. So 2PN means that it did fertilize appropriately, and that it's a normally fertilized embryo. Sometimes eggs show no fertilization after ICSI. Sometimes eggs do fertilize abnormally, and show one pronuclei or 3 or more pronuclei. Those are abnormal fertilizations, and those embryos are not cultured and are very, very, very unlikely to give rise to a healthy embryo. And your embryologist will give you a call on day 1 and let you know how many of your eggs fertilized, how many had 2 pronuclei, how many were 2 PNs,
Right.
and that's how many embryos were generated from that retrieval.
Right. And I think it's important to know that on that 2PN stage, we can tell which have now become embryos. We can't really still tell anything about the quality of the
Correct.
embryos. So they're still obviously single cells. We can't tell a lot about the quality at that point.
That is a question we get commonly. Do we know anything about grading? Can we tell anything about embryo quality on day 1? And no, we cannot. We just can tell if the egg fertilized normally. We can also tell if there are any abnormalities or there's any abnormal morphology shape of the eggs that gave rise to the embryo. But the embryo has not begun dividing yet. It has not begun developing it yet. So we can't assess how it's developing yet.
So that's a perfect segue into our next part, is talking about how these embryos develop, when we're usually looking at them, when can we start to get some ideas of the quality, the grading, and all of that.
Yeah. So the first time in which we grade embryos is on day 3. We do not look at embryos on day 2. There's no information gained from that, so we're interfering with their development if we take them out of the incubator. So the next time that we look at the embryos is on day 3. We're able to grade their development then. They also get a change in media. So your embryologist will call you on day 3 and let you know your day 3 grades. We use a fairly simple good, fair, poor system for day 3 embryo grading. And this is what we want to see on day 3. We want the embryo to ideally have undergone 3 rounds of cell division and be a even symmetrical 8-cell embryo. So we want embryos around 8 cells on day 3. So those would be considered to be good quality embryos. If the embryo is slightly out of that ideal range, either high or low, it would be considered fair. If it was very low in cell number or the appearance of the cells was very poor, it would be considered a poor quality embryo. So we do grade on day 3. We do communicate that to patients. But day 3 grading is not entirely predictive of what's going to happen at later embryonic stages. Sometimes good quality embryos don't stay good. Sometimes they don't develop well subsequently. And also the converse of that is true. Sometimes embryos that are fair quality on day 3 kind of get their act together and become good quality later stage embryos. So we do grade day 3 embryos because we think it's important to interpreting cycles, but it does not give us 100% certainty of what's going to happen next.
Right. And then that probably leads us into the next check, which would be the day 5 or day 6 embryo.
Yeah. So in most cycles, we are transferring embryos at the blastocyst stage. So this is a lovely quality blastocyst stage embryo. This is when the first differentiation in the embryo occurs. The embryo quite literally blows up like a beach ball, and there's a compartment of cells around the outside of the beach ball called the trophectoderm. Those give rise to the placenta and subsequent development. And then there's a ball of cells on the inside called the inner cell mass. They give rise to the fetus in itself, gives rise to the baby in subsequent development. So we grade embryos at this stage, and we wait. We have a grading system with a number first, which is the size of the beach ball, the size of the blastocyst, and then letter grades ABC for the quality of the inner cell mass and the trophectoderm. So Common grades might be 4AA or 3BB. We consider any grade 3BB or better to be a good quality blastocyst.
And I always get this question, you guys probably do too, when you're looking at the embryos and you have A's and B's and 5s and 4s and 3s, is there really a big pregnancy rate difference in those good quality embryos?
Once we have a good quality blastocyst, the differences between one grade or another are very small. It's kind of, it's either great, better, or best.
Right.
So if we have a good quality blastocyst, if we're transferring a good quality blastocyst, we're in a good prognosis situation.
Right. And so not always, but a lot of times this is going to be the stage where we are going to freeze the embryos at the blastocyst stage. So I think that's just a nice segue into how we freeze them, which has changed over time.
Yeah.
I think most modern fertility centers now use a method called vitrification. So if you hear that term, that is the way that we freeze eggs. So can you just tell us a little bit about that and kind of why that's used now and why that's a little bit better than the old ways?
Sure. So the modern freezing of embryos is technically not freezing at all. It's ultra rapid cooling and special solutions where the solutions don't freeze at all, so there's no ice formation. It's the ice formation during freezing that damages cells. Because the method of freezing that we use, called vitrification, there is no ice formation, so the cells are not damaged and the survival rates are exceptionally high. I'd say over 98% of our vitrified embryos survive with no damage whatsoever. That's why the majority of treatments in IVF these days are freeze-all cycles because the freezing methods are so reliable. So freezing and cryopreservation and vitrification, those are all terms that are used somewhat synonymously. And have a little image here of how vitrification occurs in actuality. So this is the image of kind of the business end of a freeze device. So this is the freeze device itself here. It is a specially shaped sterile plastic surface, and what you can see going on here is the tool in which the embryo is placed on. That's the embryo there, that small dot. It's placed onto the surface of the freeze device in a very minimal amount of media and then rapidly immersed in liquid nitrogen. So freezing is exceptionally quick. That's an important part of rapid cooled rates necessary for vitrification.
And that kind of segues a little bit into a topic that I was going to talk about a little bit later, but this is a nice segue for a little bit of a different process that you guys are still very intimately involved in, which is people that are not undergoing IVF and making embryos, people that are interested in fertility preservation and freezing of eggs. So meaning when the eggs come out at retrieval, they are going to be frozen immediately that day, which you guys always tell me this, and it just seems so crazy with all of the fancy things you do, but from what we always hear, egg freezing is probably one of the most difficult things that you can do in the IVF lab, and you have to have a really good center to do that. So kind of walk us through why that is and what the downfalls can be if you're not somewhere where they freeze a lot of eggs.
Yeah, so egg freeze cycles are exceptionally common here at Coastal Fertility. We do a lot of patient egg freezing and a lot of donor egg freezing. We're part of we're an egg freezing center for a donor network, which gives us the benefit of having lots of practice freezing eggs, but also demonstrated success rates and clear benchmarks and thresholds for success with the organization. So our embryologists freezing and thawing eggs have real robust data to say that they do it well, which may not be the case everywhere. Egg freezing is a specialized technique that eggs themselves are, rather than being an embryo comprised of hundreds of small cells, it's one very large cell. And there's lots of structural elements within the egg that are very important to its function. because we don't just need the egg to survive freezing and thawing. We need it to be able to do its job after thawing. It's a very sensitive cell. The sensitive part of freezing eggs is getting the loading of the egg on the freeze device correctly. So it is to have an experienced embryologist doing egg freezing is very important.
Right, right. And I think that that's something. Oh, we have a question.
Yes, Dee says, what if I do not have any good eggs left? My right ovary doesn't produce any viable ones and my left fallopian tube is blocked. What do I do? I'm 35.
So that you would be a great candidate for egg freezing. You know, when we are getting eggs for either IVF or egg freezing, it really doesn't matter to us which ovary they come from. It doesn't matter if you have one ovary or two ovaries, they're all going to come out to the big group. So even if we have a non-functional ovary, we can still obtain eggs from the other ovary. And the fact that we have a blocked tube on that side is really irrelevant when it comes to IVF because they're coming directly out of the ovary into the lab and we really don't need a fallopian tube there either. So as long as we're able to obtain some eggs from either ovary, really we can freeze eggs and that would give you a good chance of pregnancy later on for the most part. So that was probably a little bit more of a clinical question. I don't expect you to answer that, Dr. Gray. So let's revert back to kind of when we're talking embryos. We talked about freezing blastocysts. Very common question. Patients tell me all the time, well, my friend did this. Should I do it? Is genetic testing of embryos, or what we call PGT or pre-implantation genetic testing. So clearly from the physician standpoint, it is our job to counsel patients on if they need it, if they don't need it, what are the risks, what are the benefits, but I don't think we ever really get into how is it done? Like, what does this mean to your embryo to have it tested in the lab? So let's kind of walk through what PGT testing would look like.
Sure. So PGT testing to do PGT testing, we have to remove a few cells from a blastocyst stage embryo. And those few cells come from the trophectoderm of the embryo on the outside that gives rise to the placenta. So studies have shown, and our internal data very much show that if a few of these cells are taken very carefully and sent to a reference lab for sequencing, then that can be done without harming the embryo. And we can identify which embryos have chromosomal errors that would make them incompatible with giving rise to a healthy pregnancy. So PGT is a very important technology in the field. Certainly would dare to say revolutionary for patients of more advanced age. Allows us to identify the embryos that are viable in giving rise to a pregnancy, and rather than just transferring lots of embryos. In order to remove a few of the cells from the trophectoderm, so this is a picture of an embryo biopsy in progress. So this tool here we're using to aspirate or suck up a few of the cells from the trophectoderm. The target here is microscopic laser that's in our micromanipulation microscopes. So we use the combination of suction and that microscopic laser to remove about 5 cells from the trophectoderm, which is several hundred cells at this point in time. Those 5 cells are placed in a DNA amplification tube. And that amplification tube is sent to the genetics reference lab. The genetics reference lab amplifies that DNA and then sequences it, and then essentially does chromosome counting to make sure the appropriate number of chromosomes are there, and there are no other large chromosomal errors in an individual chromosome. They can see, deletions of a chromosome, or if a chromosome has an extra piece. And that's what they're doing with the PGT testing.
Right. And I get this question a lot too. So just to kind of reiterate, Dr. Gray said, the tissue, the couple cells that we remove, those are the ones that are going to get sent out of our facility for testing. As soon as the biopsy is performed, the actual embryo is frozen, just like we talked about before, and that remains at Coastal Fertility.
Yeah.
So the embryos are never leaving the facility, just the sample cells are leaving the facility.
Yeah.
All right, well, I think I have gone through kind of my whole IVF process. Do you have anything that I have forgotten on IVF terminology, processing, things you guys do on a regular basis?
Well, we were just talking about embryos staying in storage at Coastal Fertility.
Yep.
I think that's a good opportunity to touch on how embryos are stored at Coastal Fertility. So we do have on-site embryo storage here at Coastal Fertility. We do have a 24/7 tank monitoring system. So that monitoring system has temperature probes on the inside and the outside of the tank, and if there is, they are alarmed to contact all the embryology staff if those temperatures deviate from acceptable norms. So it's a very robust system with redundant modes of call out. The tanks are physically checked daily. The liquid nitrogen levels are measured twice a week. The tanks are filled every week. So we take great care in maintaining the safety integrity of stored embryos here at Coastal Fertility.
Right. And I think this is an underestimated part of a fertility center. And I try and tell my patients this, but when you actually look at fertility centers and national pregnancy rates reported by fertility centers, there is a wide range of success rates, meaning IVF at Clinic A might not be the same as IVF at Clinic B across the country. And yes, the doctors maybe have a little bit to do with that. We'll take a little credit, but the vast majority of those success rates and pregnancy rates come from the embryology lab. Hands down, 100% of the quality of the embryology lab. Obviously, I am biased. I think our lab is amazing. We have pregnancy rates sky high, and we're going to take one question before we kind of get into why that may be.
What is the cost for storage of embryos?
So a lot of it depends on if you have coverage for storage. It's not a huge fee, and I don't want to quote this incorrectly, but it's usually around $300-ish every 6 months or so, somewhere in that range. So it's not these massive amounts of dollars people think about when they think about IVF generally. So kind of going back to our lab, to Coastal, I think one of the huge things is we have a great team, we have a robust team, we have you as our director who is on site, which I think people don't realize. A lot of centers don't have an on-site lab director, and so they may have a lab director that's kind of monitoring their lab from another state that kind of flies in, every month or every other month just to kind of check on things. But Dr. Gray is in our lab every single day. He's helping his team with embryology work. He's keeping an eye on things every day. So what are the other things that we do in our lab to kind of make our pregnancy rates so much better than a lot of other centers?
Right, myself as the on-site laboratory director and a hands-on embryologist, the things that I work on to optimize, in addition to the technical quality of all the work that goes on in the lab, is maintaining peak performance of all the equipment in the lab. That's all of the incubators and micromanipulation systems, keeping those tuned up to top performance. A sometimes underestimated, but in my opinion, very important part of the quality of outcomes of an IVF lab is maintaining the cleanest laboratory environment possible. And that means the safety of the materials used coming into the lab. A very big portion of it is air quality. Air quality coming into the lab. So we do have, a IVF specific air handler unit where we have specifically optimized filters to maintain air quality at optimal levels throughout the year. So these are things myself as an on-site lab director work on day in and day out to monitor systems, to improve systems, to work with field experts, cutting edge research to make sure that our lab functions in the best way possible and patient outcomes are at the highest rate possible.
And I think Dr. Gray's right, but even we underestimate even things like pollen season in Charleston, and these little things we take for granted can really affect air quality. So just staying on top of those things is really of critical importance.
Yeah, pollen and heat.
Pollen and heat.
Yeah, we have plenty of those, and they definitely affect air quality. So learning how to deal with those in a very robust fashion has been something we've improved over the years to improve the consistency and pregnancy rates at very high levels, which is what we want to do for every patient.
So I think that's all my questions. Do you have any? Oh, Holly has one more question.
Can you guys just quickly tell us why July 25th is World Embryologist Day?
July 25th is World Embryology Day because it is the birthday of the first child born from in vitro fertilization, Louise Brown, born in United Kingdom. She's the first in vitro fertilization baby. I think she's in her 40s now.
Yeah, 1978.
Yeah. So that's why I think it was kind of created a few years ago, and this was chosen as World Embryologist Day, but for that reason.
We have come a long way since then.
We have.
Let's done that. It's a whole new world. All right. Well, I really appreciate, Jeff, you coming in to talk to us today. I think this is a very unique Facebook Live that we got to do. And if you guys have any other questions, please feel free to reach out to us. Thank you, everybody.
All right. Thanks, everyone. Happy World Embryologist Day.